Okay, good morning, everybody. Today we're going to talk about abdominal emergencies. And as we start, this is one of those calls that it comes out, nauseous, vomiting, stomachache, things like that. And it's one of those calls that we don't immediately go into our minds of the same nature as like a cardiac arrest or MVC, things along those lines. But there are some true emergencies associated with these dispatches. So today we're going to aim at trying to evaluate, the importance of these simple, I'm doing the quote fingers, boring calls that are historically calls in the fire service that aren't treated with as much respect as other calls. But we're here to change that. So we're going to go over abdominal emergencies, and some of the ones we're going to talk about are your kidney stones, appendicitis, your AAA is also called the abdominal aortic aneurysm, liver and spleen injuries, and constipation. So we'll dive right into it with the kidney stones. And the kidney stones, I've got some pictures associated with each of these images to help us see better what exactly is happening. But these are deposits within the ureters of the urinary system, which connect the kidneys to the bladder. They're hard deposits. They could be like calcified calcium, things like that, minerals, various salts. They're caused by, having an improper diet, obesity, various medications. We're not really searching too much for the cause because we can't see what exactly is going on. We're just looking at the signs and symptoms and marking our treatment from there. So these are some pretty defining signs and symptoms. And as we dive into them, I talked to one of our firefighters who works here, and he's had kidney stones, and he says it's the most painful thing he's ever experienced. And he said it's a legitimate, to him, it was a legitimate 10 out of 10 pain. And that's one of those things that I put in my mind when people are having these, they are in significant pain. So some of the signs and symptoms of your kidney stones, you're going to have severe sharp pain unilaterally on one side. You could have them on both if you have kidney stones in both. This could be caused by this stone passing through these tubes going to your bladder. The pain radiates from the lower abdomen to the groin, and it can move, or it will move, as the kidney stone travels down to the bladder, and it can come in waves and fluctuate in intensity. And this is due to the movement of it, or if it's not moving, or if you have some urine backed up behind it. So it's a fluctuating, moving, severe pain. It's kind of on one side of the body. It's kind of whenever I hear those words, whenever I hear a patient describe that, my mind goes to that. It doesn't eliminate other possibilities, but it goes to that. So you can have pain and burning while urinating, nausea, vomiting. You can have an increase in frequency of urination because the urine's backed up. Oftentimes the patient will know exactly what they have because they've had them before, but there's, if you've had them before, you've never had them, so there's always that one time where they don't know what it is. But these are, I'm gonna, tell the truth here. Some of the patients I've seen the most pain are kidney stone patients. It's a significant, serious pain that they're experiencing. So with that being said, that's our kidney stones. All of these could be medical emergencies. I'm not saying not to treat this as not one. This is generally, something that they go in and they have a stone broken up. They get a little pain medicine, things of that nature. So now we'll get into appendicitis. So this is inflammation of the appendix, which is a little organ on the large intestine that they do not know exactly what it does. It may not have a purpose anymore. So it's just a little pouch on the large intestine at the beginning of the large intestine. Now, some of the key words that you can hear that associate appendicitis is, the patient's age. Frequently, appendicitis occurs between people 10 and 30 years old. It can occur in any portion of the population, but this is frequently where it occurs. And this is a true medical emergency, rupture of the appendix. Now, keep in mind the appendix is part of the intestinal system, the digestive system. So with the large amount of bacteria located in these regions, if you were to have a rupture of the appendix, you're going to have a spillage of fecal matter and of bacteria and their byproducts within the the abdominal cavity. So this rapidly leads to serious infection. So the goal is to get these patients to the hospital prior to the rupture of the appendix, which, you know, it ranges in intensity, but or in duration. But I heard it's you know, I've heard of an instance, I believe it was 48 hours. They said if you didn't get here in 48 hours, you had an issue, something along those lines. I remember 2 days sticking out on this particular patient. So, but it can vary due to the degree of infection. Regardless, it's a true medical emergency. So how do you, determine appendicitis? So we'll look at the signs and symptoms. So the pain is generally in the lower right quadrant of the abdomen. Now in a pregnant patient, it's a little bit higher because of the appendix is higher due to a baby being inside of the patient. So, but generally on your normal patient, it's going to be in your right lower quadrant. Now, initially when the appendix begins becoming infected, the pain will start in the middle of your abdomen, and then it will migrate to the left lower quadrant. So it'll migrate to that quadrant, and they'll have feelings of nausea and vomiting. And since it's an infection, fever will occur in 40% of individuals. So this is get them to the hospital before the appendix swells and ruptures. And because once that happens, it's a life-threatening condition. They're fighting for their life. This is a life-threatening condition prior to rupture. So if you suspect appendicitis, one of the things you can do, there's many tests. One of the things that you can do is check for Bloomberg sign, which is a rebound tenderness test. So on my left lower quadrant, you're going to push in, and it's not going to hurt them anymore. But when you release, that release is going to, they're going to, that's where the pain's going to be felt, is during the release, the rebound of that palpation. So that's one of the tests where you can check for appendicitis. But some keywords to remember: patient age between 10 and 30, left lower quadrant pain, fever, and rebound tenderness. So that's a true medical emergency and should be treated as such. Our next one, abdominal aortic aneurysm, the AAA. So this is the aorta, the largest artery in the human body, comes directly off the heart. Does a turn down, and it's this region. It's an abnormal enlargement of this area. This is a significant condition, because what happens is the aorta balloons out, as you can see here. So that ballooning is a weakening of the walls, and it's just a matter of time or pressure that will cause this aorta to rupture. And then when that happens, from what I was told in the hospital, when that happens, unless they're on the operating table, they're not going to make it, when the aorta ruptures. So it's an enlarged area of the aorta that may lead to a rupture caused by hypertension, trauma, atherosclerosis, which is a hardening of the arteries, which can the cardiac, you hear the cardiac risk factors. This is part of the cardiovascular system. So true medical emergency, very, very serious. So some of the signs and symptoms are a deep, constant pain in the belly area. They can have back pain, and there's a pulse near the belly button. Now, if you feel a pulse near the belly button, don't sit there and poke at it. Identify it and get them transported. You don't want to agitate that, because the rupture of that is deadly. So now, liver and spleen injuries. This is a very important one. And this is one that and we'll talk about it a little later. This is one that you really find out about by following up with the transport medics. So there have been, several vehicle accidents in which the patient will be, a green patient walking around with a little stomach pain, the shoulder might hurt a little bit. Green patient, that's it. And they get to the hospital, and that's all we hear. And we assume they went there, got an x-ray, went home, all is well. But in reality, following up, there have been several instances when I followed up on some MVCs, and it turns out the patient was flown to USA due to a spleen or liver laceration. So these, this is where you learn these things, is by following up with the crew. So your liver and spleen injuries, you can see these are very large organs in the abdominal cavity, very high rate of blood flow. They have they're very important organs, very bloody organs. Laceration to it is a significant event. I found this quote very interesting from a reputable source. I copied it word for word because of its significance. It says the spleen and liver account for approximately 70% of all visceral injuries caused by blunt trauma, by far the most commonly injured intra-abdominal organs. So that should give you you should highly suspect some kind of injury in these patients with a blunt force trauma, particularly the vehicle wrecks, where the seatbelt could press on that area if it's not properly applied, or if they, depending on how they're wrecked. Organs with massive blood supply laceration could be life-threatening, true medical emergency. Now, some of your keywords on this is the shoulders. So these are how you can improve your assessment on liver and spleen injuries. The shoulders can help tell you what you need to know. So, and we'll get into that here. The liver, you're going to experience abdominal pain, right or left abdominal pain. Well, if we look at the liver, we can see that it's on both sides. So depending on where the liver is lacerated, it could be on either side. So, high abdominal pain, okay, that's a key word. It could be a seatbelt injury. Right shoulder pain. So if they have referred pain to the right shoulder, that's the key word right there that I'm suspecting that the liver has been lacerated. So I've been on a couple wrecks. How are you feeling? I've got some shoulder pain and abdominal pain, and I hit my head a little bit. Right there, I'm looking at head injury. I'm looking at liver or spleen damage because of the referred pain. Being a bloody organ, an organ with a massive blood supply, they can experience symptoms of shock, signs and symptoms of shock, which we know are high heart rate, low blood pressure, things of that nature, confusion, altered mental status. So liver is going to be your right shoulder pain. Spleen, that's generally presents with pain in the upper left stomach. As you can see, it's more so on the left side of the patient. So that's the area where the feeling will be felt, the pain will be felt. That refers to the left shoulder when it radiates its pain. So you can have the pain in the upper left stomach and pain in the left shoulder. So keep those locked into your mind on these car wrecks, on these, if someone's hit with a baseball bat in the stomach, things of that nature, the shoulder pain. They can also have symptoms of shock. So it's things like that. Now, is it right shoulder pain, left shoulder pain? I know the right shoulder pain is liver, the left shoulder pain is spleen, but in all reality, if you have a laceration to one, you very well may have a laceration to both. And the treatment being large organs for pre-hospital treatment, our goal is to get them transported. So we're going to essentially treat them the same. That's a physician issue, a surgeon issue to further diagnose and treat that. We have to recognize that there's some internal damage there, and they need transport, they need surgery. So that being said, constipation, this is a condition in which a person has uncomfortable or infrequent bowel movements. They can be caused by diet, lack of fluids, lack of exercise. Narcotics can also lead to constipation, and that's one of the more common ones that I've seen causing constipation, because generally a person that has a less than ideal diet, or they don't drink as much fluids, they're not exercising, they've had frequent bouts of constipation. It's the person that's recently broken their leg that is prescribed a narcotic painkiller that suddenly has constipation. They don't understand why their stomach's hurting very bad. Those are the kind of things that'll trigger you on those. The 80-year-old woman, when you walk in and she has abdominal pain, a lot of the times they'll tell you that it's constipation. I haven't had a bowel movement this long. It's the one that are prescribed the narcotics that don't understand what's happening. So some signs and symptoms of constipation, it's generally defined as fewer than 3 bowel movements per week. You can have hard, dry, and lumpy stools. We'll talk about that real quick. The stool will typically come out pebble-like, like little pebbles. It's not forming together as a unit. So what happens, just a quick bit of physiology of the digestive system, the large intestine, the liquid nutrients enter, or the stool that enters the large intestine from the small intestine begins the process of having water extracted from it the entire length, with a significant extraction of water in this descending portion of the large intestine. So with that being said, when the stool gets here and it gets stuck in this region, the water's being pulled out of it, and now it's having a harder time moving. And since it's having a delayed time moving, a delayed response to movement, it's going to sit there and the water's going to keep pulling out. And eventually it'll get to a hardness to where it can't move any further. So it'll back up here, and it can back up throughout the entire length in severe cases, excessively in severe cases. So some of the things that you'll notice, they'll tell you that they're straining or they have pain when they're passing stools. They're having small stools. They may feel like they can't completely empty their bowels. During palpation, it can occur in any area, but during palpation, the last constipation I ran, he had a hard mass below the belly button, below the navel. And he also said that he had foot surgery, started taking narcotics. So that's one of those things that are should highly, you should have a high suspicion of constipation with some of those keywords. So it's, the lumpy mass during abdominal palpation. So that's your constipation there. And, you can imagine it could back up, left untreated, you're not moving any stool, could turn into a medical emergency. Remember all that bacteria in there, and if there's a potential for a rupture, however that plays out, however long they're constipated, could make you pretty sick. So with that being said, here's some tips that I've seen, heard, experienced in my career out in EMS. You palpate the painful area last. So when you're doing your palpation of the patient, where does it hurt? Oh, it hurts down here in my right lower quadrant. If they're saying that it hurts down here, well, I'm not going to go right there and start palpating that area. I'm going to start farthest away from the painful area, because what happens is when I palpate here, now all of a sudden everything hurts. So you've ruined the accuracy of your assessment, and that's something they teach with palpation of the abdomen. Always start away from the painful area and move in toward the painful area. As you're doing your assessment, watch the patient's face. This is important in the elderly generation that hide pain real well. They may not want to react, but watch the patient's face when you're palpating. That can tell you a lot of what you need to know. Glance up and see if they're grimacing, things along that line, because they can give you subtle clues that can help you identify the area of injury. Guarding, if you see a patient that's guarding their abdomen, like they're not wanting to let you near it, they're hiding, in a sense, you could make the comparison to a wounded animal, where they're guarding. They've most likely got a pretty serious pain. They don't want anything near their abdomen. It's a get away from me. It's okay, this is a problem. Be professional and explain the importance of an accurate assessment to yield an accurate treatment to them. But that's you'll see serious abdominal injuries. They'll be guarded. CS-15. They go. Can anyone hear me still? I had a little internet issue. I think
yeah, you froze up right after you were ending up the guarding.
Okay, great, thank you. So I ended at the guarding. So that's a significant sign that you can determine if the patient's having an issue or not, a medical emergency or not. So now we're at the tips. That was the end of the guarding scene. So this is the last slide, the tips. Did I cover anything on palpating the painful area last?
Yes.
Okay, and the patient's face, I've got that covered. Okay, guarding, got it. Okay, gotcha. So you got all that. Great. So follow up with the transport crews. This is something that, we've touched on it a little bit earlier, and it is you got the green patient from the NVC, you're doing the pass on, had some stomach pain, a little shoulder pain, probably from the seatbelt, we think, and they hit their head, but they're fine, GCS at 15. Green patient just needs a trip to the hospital. Seen that before. And then what happens is they get to the hospital, you follow up with the crew, and the crew, you run the call at midnight, the crew tells you, Yeah, they flew them out. They did some assessment, some images, and they had a lacerated spleen. I remember that being one. And then it put two and two together that, oh, this shoulder was hurting, the spleen, right shoulder. Yeah, that makes sense. Won't let, that shouldn't have happened in the first place, It's things along that line where if you don't follow up with these transport crews, if you're able to, they're one of your greatest sources of information on doing your assessments. Because, we could go 30 years thinking we're right, but how do we know if we're right if we never get the answer? So use those transport crews when you can to figure out if your assessments are good and learn from those. Of course, at the hospital, they have all of the equipment to do the checks that they can do. So you're gonna learn a wealth of information, and you're gonna learn some great assessment tips and where you went wrong, where you went right, things of that nature. That's probably one of the greatest tools that I've ever used, is following up with those transport crews on what it really is. So with that being said, that's the abdominal presentation on abdominal emergencies. The goal of it was to help us realize that nausea, vomiting, stomach ache, we shouldn't just assume that these are just, a flu or something. That there could be a lot more to it. So does anyone have any questions or experiences?
I've got a question.
Yes. Yes, sir.
Ectopic pregnancy, does that fall under abdominal pain?
It would fall under abdominal pain. And as a matter of fact, in the and I cite the Acadian protocol on it, that it is listed in there, that ectopic pregnancy, under that protocol, any woman of childbearing age that you suspect that they could be pregnant, you should expect the ectopic pregnancy, and that is a true medical emergency as well. Yes, that is one of those things where if you get a 25-year-old female, sudden pain, your mind goes there first, because that's a very serious issue. And that's where those questions.
Okay.
Go ahead, sir.
Yeah, another question is on your kidney and say any abdominal pain. What about analgesic? What about the pain? What are we doing for pain? Or what's the process you're thinking on pain medication for those?
So the process I'm thinking on is with these patients that are, we'll use the kidney stones example. On the patients that I am suspecting pain, one of the things that I always like to have, because we're limited in our pain supply, or our pain medications, we do have Toradol, which is very effective for things like this. That is one of the things that we would administer for abdominal emergencies such as kidney stones. There is a lot of talk about, and I feel like I may know where this question might be headed, because I remember a lot of the older medics, the more seasoned medics would take, they would say that by where was that at?
New Hope Lane.
Okay. If the answer you were asking was to have if you should give pain medicine or not, a good physician can read through pain medication is what we were talking.
I've got a couple things I'll add once they call it, once they dispatch.
Altered level of consciousness and mental status. Q3, Q15 new head warning. Q3, Q15 new head warning.
So Chief Sullivan, to help answer you, Toradol is awesome for kidney stones, but it also kills the kidneys. So you got to be cautious using it, because Toradol will put a patient into right-sided renal failure, and they're already having issues with their kidneys. So you have to be careful with it. Any mid-abdominal pain with a AAA, you have to be cautious with, because of the vasodilation you're causing and the amount of blood that's fixing to dump in that area of that AAA. So if you do come across where you have that pulsating belly button, or you hear heart tones in the stomach, then you got to be real careful. That's when you got to step back and weigh your options of they can deal with a little pain until you get them to the hospital, and they can do an ultrasound or a CT to rule it out, especially if they have a history of AAAs.
Exactly. And that's the point, is that we get into these situations where we say pain control is one of the first things we want to do. But in this case, you got to be really, really careful, because that could get you into a problem. That was the point.
I'd rather err on the side of letting them have a little pain than actually causing that AAA to rupture, because they don't have a chance then. And then to help y'all a little bit on the appendix, if they say every time their right foot hits the ground, it hurts, that's one of the tail signs of appendicitis, and it's inflamed and it's probably infected pretty bad. Is every time their right foot hits the ground, it shoots a pain up from their hips up through their back, is a telltale sign of that appendicitis. I took notes while he was doing this. So the spleen is actually a large filter for the body that you can live without. All it does is store extra blood. So if you do have a small bleed or something going on, then the body's natural reaction is to pull blood from that spleen to get out to the body, so that you don't go hypovolemic as quick during traumatic injuries. The spleen will start dumping a lot of blood for you. All the stores it has, it can store up to 1.5 liters of blood in the spleen. You can live without it, but you can't live without a liver. So that's the big one, is the liver problems. If you have somebody that flashes yellow on you from a real bad car wreck, they've dumped a lot of bile, and they will turn yellow just like somebody that's in liver failure. So if they've lacerated or completely mangled their liver, they'll start turning yellow, and you'll see it in their eyes first. So that's just a little help if you're on a real bad car wreck or something like that, or somebody that's been shot in their liver. If they start dumping a lot of bile, you'll see their eyes start to turn yellow. That's about all I got.
All right, Chief, I think you could stop the recording.